Hello, today we are discussing on clinical features of portal hypertension in children. Portal hypertension means when portal venous pressure is above 10 to 12 millimeter of mercury. The normal portal venous pressure is 5 to 10 millimeter of mercury. The clinical features of portal hypertension. Number 1, the commonest clinical feature is gastrointestinal bleeding, which is the first presentation in case of extrahepatic portal venous obstruction, and this is the commonest cause of portal hypertension in case of children. Most common GI varices are hematemesis and melena. At anorectal varices, you may get hemorrhoid bleeding, and caput medusa, the collaterals on the abdominal wall radiating outward from the umbilicus. All these anastomosis sites I have discussed in my previous class. Number 2 clinical feature, splenomegaly. It is a cardinal sign of portal hypertension and second most common clinical finding in case of portal hypertension, especially in the extrahepatic portal venous obstruction. Splenomegaly is almost universal, and this is the commonest cause of portal hypertension in case of children. And soon after bleed, spleen may not be palpable always. Number 3 clinical feature, ascites. Ascites is a sign in case of 7 to 21% of children only, because this is commonly seen in the hepatic causes of portal hypertension, and in children extrahepatic portal hypertension is more commonly seen, and in extrahepatic it is more rarer. It is seen in 0 to 36% cases of portal hypertension in extrahepatic portal hypertension. Number 4 clinical feature is again jaundice, and jaundice if it is due to hepatic cause, intrahepatic cause or hepatic causes of portal hypertension, you will get jaundice. Number 5 clinical feature, dilated abdominal veins. In advanced cases you will get this, and this is mainly seen in hepatic causes. Absence of dilated abdominal veins does not exclude portal hypertension, because many times extrahepatic portal hypertension you will not get the dilated abdominal vein. This is more commonly seen in hepatic causes. If there is a paraumbilical vein, this indicates intrahepatic portal hypertension. If there are back veins which are dilated, this indicates hepatic vein outflow obstruction. Another clinical feature is hepatomegaly, enlargement of the liver, and in this consistency is more significant than the size. In extrahepatic causes of portal hypertension, the liver consistency is normal to soft and the liver is small in size, whereas in hepatic causes it is more firm, nodular, and then decrease in the vertical liver span. If the left lobe of the liver is palpable, this usually indicates it is cirrhosis of liver. Number 7 clinical feature is encephalopathy, and more than 50% cases you can get this feature, especially if the cause is cirrhosis, and that is again hepatic causes. This encephalopathy is never seen in extrahepatic causes of portal hypertension, and extrahepatic cause is more common in developing country like ours. So encephalopathy in our setup is less commonly seen. Another clinical feature is hypersplenism, thrombocytopenia, and there may be anemia due to secondary to GI bleeding, and maybe also due to hypersplenism, and there is growth retardation in a child. Another clinical feature is fetor hepaticus. This results from portosystemic shunting of the blood, which allows the mercaptans to pass directly to the lungs, and you get the smell. So this is known as fetor hepaticus, that is the smell of these mercaptans. Another clinical feature is hepatorenal syndrome. You get renal insufficiency or acute kidney injury, but there is pathology is not in the kidney, but due to the pathology in the liver, you are getting the clinical feature of the kidney or renal insufficiency. So this is known as hepatorenal syndrome. Another is hepatopulmonary syndrome. Again, there is no pulmonary disease, but because of the hepatic cause, you are getting pulmonary symptoms known as a hepatopulmonary syndrome. This is recognized by the triad. There is portal hypertension, intrapulmonary vascular dilatation, and arterial hypoxemia with the partial pressure of oxygen less than 70 mm of mercury. So child will be presenting with dyspnea, cyanosis, clubbing, spider nevi, but there is absence of any cardiopulmonary disease, but symptoms of cardiopulmonary disease you are getting because of the hepatic disease known as hepatopulmonary syndrome. Just few pictures showing splenomegaly, hepatomegaly, and then dilated abdominal veins or varices. These are the varices which bleed ultimately, and this is ascites usually seen in hepatic causes of portal hypertension. Pot belly, because of ascites, there is a smiling umbilicus or everted umbilicus you can see, and all engorged veins due to the vessel obstruction. And you may also get features of chronic liver disease if the cause is chronic liver disease for portal hypertension. So those features can be clubbing, palmar erythema, spider nevi, angiomata, gynecomastia, feminizing hair distribution, testicular atrophy, small irregular shrunken liver. You may get anemia and caput medusa. Now come to investigations. You have to do complete hemogram, WBC, RBC, platelet, all these things are seen. Liver function test, and especially important is Pratham vein time. So liver function means bilirubin with all the liver enzymes. And number 3, non-invasive investigations like ultrasonogram, CT scan, MRI of liver and spleen to see the morphology and status of splenic and hepatic vein flow. USG ultrasonogram is showing patency of the portal vein, esophageal varices, vascular anatomy or the collateral vessels can be seen, increased echogenicity in the cirrhosis, diameter of portal vein, it is more than 12 mm in portal hypertension, and cystic dilatation of intrahepatic bile duct can be seen in congenital hepatic fibrosis. Doppler flow USG study detects the portal vein dilatation and direction of the flow within the portal system, and also you can see the diameter of the portal vein. Normally the portal vein diameter increases during inspiration, but in case of portal hypertension this diameter remains same in inspiration and expiration. So if the portal vein diameter is remaining same during inspiration and expiration, this indicates portal hypertension. Now number 3, invasive procedures. Contrast enhanced CT or MRI, also known as portal angiography, can be done to find the site of obstruction. So in this, number 1, splenoportovenography is done, which measures the splenic pulse pressure. Normal is 8 to 12. If it is more, then it is portal hypertension. Number 2, percutaneous transhepatic portography. Number 3, inferior venography, venocavography. Inferior venocavography is done. Other invasive procedures are endoscopy. Esophago-gastroduodenal endoscopy is done to demonstrate varices and identify exact site of bleeding. And then also you can do the endoscopy for ligation or sclerotherapy to stop bleeding. So endoscopy will help you for diagnosing as well as in a therapeutic procedure also. This is also a therapeutic procedure. Another investigation is barium swallow, which is not done these days. If there is no facility or availability of endoscopy, then you can take the support of barium swallow. Other investigations are colonoscopy or liver biopsy. Thank you. We'll come again with the treatment part.